Professor Mohammed Mitwali from Asyut University. He's gonna give his talk about assessment of pulmonary patient prior to bronchoscopy.
بسم الله الرحمن الرحيم. طبعا في الأول أحب أشكر أساتذتي على الدعوة الكريمة، الأستاذ الدكتور طارق صفوت، الأستاذ الدكتور عادل خطاب، دكتور ياسر مصطفى، والدكتور عماد قراعة، وأخويا الدكتور أشرف مختار مدكور. أنا إن شاء الله النهاردة هتكلم عن assessment of pulmonary patient prior to bronchoscopy. الكونتنت ان شاء الله هتبقى بتاعت السيشن. التوك هنتكلم على البريبريشن والانفورمد كونسنت، جنرال اسسمنت، الهيستوري والفيزيكال اكزامينيشن، لابوراتوري تيست وايمجنج، الايفالويشن والانديكيشن والبلاننج للبرونكوسكوبي which is very important, and in البرونكوسكوبي in some special situations like a respiratory patient, cardiovascular, anticoagulated patient, old age, and in the ICU. We'll start with preparation and informed consent. As English is not my mother language, I searched the definition in Google, and it says it's a process for getting permission before conducting a healthcare intervention on a person. ده الجنرال definition. طبعا relevant to complete patient information للdiagnostic والtherapeutic procedure بتبقى should be obtained from the patient. والكلام ده فعلا اتلقى ان هو بيحسن البيشنت tolerance to the procedure. لما العيان يبقى فاهم ايه اللي هيحصل معاه بيقدر يتحمل برونكوسكوب اكتر ويبقى cooperative معانا during the procedure. Clinician should be able to explain the procedure. لازم نعرف العيان ايه اللي هيحصل بالظبط، الاسوشيتد ريسكس مع المشكله دي، ايه اللي ممكن يحصل، ايه اللي يحصل. وطبعا مهم قوي ان نقول ان الريسبونسبيلتي اوف ذا دكتور هو بيرفورمز ذا اكزامينيشن انه يبقى هو اللي ياخد من العيان valid consent. يعني ما فيش حاجه اسمها انا استاذي بعت لي الحاله ديت اعمل لها منظار فانا بدخل العيان واعمل له منظار. انا اتس ماي ريسبونسبيلتي اللي بيبرفورم البرونكوسكوبي يعرف العيان الريسكس والكومبليكيشنز، ولو العيان ما يوافقش خلاص مش مشكله، ما فيش دايجنوزس بالعافيه، انما لازم يبقى تاخد منه الانفورمد كونسنت. طبعا الجنرال اكزامينيشن، الجنرال اسسمنت زي الهيستوري والفيزيكال اكزامينيشن مهم قوي ان ناخد ديتيلد انفورميشن على البيشنت كارنت والباست ميديكال هيستوري. مهم قوي ان ناخد طبعا السموكينج هيستوري، الاوكيوبيشنال اكسبوجر از فيري امبورتنت، كوموربيديتيز زي الازمه والسي او بي دي والكارديوفاسكولار بليدنج ديس اوردر زي ما هنشوف، ليفر رينال ديزيز، all these are very important في الهيستوري تيكينج. دي كانت حاله عيان جاب bilateral lung masses و underwent fiber optic bronchoscopy. We saw this endobronchial lesion, and on biopsy it proved to be stony hard to take a biopsy. It was horrible. The biopsy forceps was going to be broken. And after careful history examination, it turned out to be progressive massive fibrosis of silicosis. So it's very important the occupational history to take before the bronchoscope. Other issues is of course the basal physical characteristics of the patient. So the patient I should know the heart rate, respiratory rate, blood pressure, and oxygen saturation before the bronchoscopy procedure to assess if any change in these parameters is due to the bronchoscopy itself or it was present at baseline. Visual assessment of the patient to detect any signs of respiratory distress, superior vena cava syndrome, stridor, hoarseness, anatomic abnormalities in the face. All these are very important. Lung auscultation is also very important. Sometimes you go directly to the bronchoscope without auscultating the patient. At least you know if the patient is wheezy or not, or have crepitations or not before the bronchoscopy. So if he develop wheezes after the bronchoscopy, you know this is because of the bronchoscope, and if these had existed previously or as a consequence of the procedure itself. Performance status is very important because any investigation should lead to a change in the management plan. So if my bronchoscopy or if my procedure is not going to change the management plan, no need to go in this risk, especially in terminally ill patient. So I'd like to know if you would like to bronchoscope a patient like this or just leave him to die in peace and not in pieces. Laboratory test and imaging, CBC, platelet count, renal and liver function, as I said. Specific situations like patients with heart disease, do electrocardiogram, ECG. COPD patient, we will see later that we need arterial blood gas analysis to know if they are hypoxic or not. Imaging studies, X-ray, chest CT, and chest ultrasound are very important to analyze before the intervention to plan for my procedure. For example, this table shows all what we said right now. This planning is mandatory for every invasive technique, so we should be aware of the indication, contraindication, and possible complication. And only performed in patient in home, as I said just now, the diagnosis is going to alter management and where the benefit outweighs the risks. For example, this is a case of central located lung mass, so it will be easy to take a biopsy with the bronchoscope. But if I see this patient with left side pleural effusion with underlying collapse, CT show the lung mass underneath this effusion. So would you like to make a bronchoscope right away and see this picture of extrinsic compression from without because of the effusion, or would you prefer to make a thoracocentesis and make a pleural aspiration for this patient? This is all planning for your patient. Another patient with this peripheral lung mass, so it's easy to know that if you come from central airways, it's very impossible to meet this lung lesion and take your biopsy, but you should at least prepare your C-arm fluoroscopy to make the biopsy. If you're going with the bronchoscope, electromagnetic navigation if you have it, or you can take it from outside either with C-arm or either with CT or chest ultrasound guided biopsy. This lesion, for example, shows a positive bronchus sign, so it's easy to go with the bronchoscope in this peripheral lesion to take a biopsy. But would you like to take your biopsy with a regular bronchoscope like that, or you should prefer the ultra thin bronchoscope so you can go peripheral and take your biopsy? These are all planning for your biopsies. This table summarizes the different biopsy techniques for each lesion. For example, for the endoluminal lesion, it's better to take an endobronchial biopsy, and endobronchial needle aspiration will give the highest benefit, but brushing and washing will be of less benefit. And of course, bronchoalveolar lavage will be of no benefit. Peripheral lung masses, maybe I have benefit from brushing, bronchoalveolar lavage maybe, washing maybe, but of course I will need the endobronchial ultrasound or electromagnetic navigation bronchoscopy to take a biopsy from this peripheral lesion as we just mentioned. This is in transbronchial needle aspiration for lesions outside the tracheobronchial tree. Another indication is the patient performance status and life expectancy. As we saw in this terminally ill patient, in the ACCP guidelines for patient who will need to take chemotherapy, terminally ill patient, grade 4, stage 4 malignancy with distant metastasis. Who will you send to take chemotherapy and who is not going to take a chemotherapy? They made a rule of thumb. As they said, after exclusion of the time of sleeping, about 8 hours, let's say 8 hours. So you have 16 hours of day time. We should all awaken these 16 hours. If the patient stay more than 50% of this awakening time hours in bed, so he is really terminally ill and should not undergo chemotherapy. So if we stay more than 10, 12 out of this 16 hours of the waking time, so you should leave the patient to die in peace and not even make chemotherapy give chemotherapy for him. Also, the choice of the right interventional technique between laser therapy, mechanical debulking, electrocautery, cryotherapy, these techniques needs the evaluation, and these are outside the scope of this presentation. For bronchoscopy in special population, for example, the respiratory patient with severe COPD with FEV1 less than 40% or FEV1 less than 1 liter should undergo arterial blood gas before bronchoscopy. Sedation should be avoided, and of course supplemental oxygen therapy should be given with caution, so no very high concentration of oxygen for this patient. In the presence of highly hypoxic patient, it's possible to make your bronchoscopy under non-invasive ventilation with face mask. So you give the face mask, you resolve the problem of hypoxia, and you make your bronchoscopy. If it's possible, if it's not possible to ensure adequate oxygenation, so delete your bronchoscope. No need to make more hazard to your patient. Arterial oxygen tension above 60 millimeter mercury and saturation above 90 is considered sufficient to make your bronchoscopy. And of course, asthmatic patients who are more prone to develop bronchospasm, it's better to give inhaled bronchodilator before the procedure, so not to go in asthma attack. Cardiovascular patient, recent myocardial infarction should lead to postponing of your bronchoscopy to 6 weeks. Unstable angina, poorly controlled congestive heart failure also postpone your bronchoscope till control of the condition. Anticoagulated patients should suspend the anticoagulation to 3 days earlier than the bronchoscope. If it's absolutely necessary, so you can give heparin. Regarding antiplatelet agents, a study conducted on clopidogrel or Plavix increased the risk of bleeding and should be interrupted 5 days, مش بس 3 days. So patients on clopidogrel should be interrupted 5 days before the bronchoscope. Aspirin is considered safe, and studies did not show that it lead to significant bleeding. If transbronchial lung biopsies are to be performed, it's essential to check the platelet count per thrombin time و thromboplastin time. مفيش يعني هو في الحقيقه assessment of pulmonary patient prior to bronchoscopy, there is a big lack in evidence-based literature in this subject. انما 50,000 platelets is considered to be safe for biopsies. Prothrombin time or partial thromboplastin time within 1 to 2 seconds of the control is also considered safe for the bronchoscopy. What about age of the patient? We all afraid that old age patient, maybe above 80, to do a bronchoscopy, but literature also did not recognize any specific problem with this patient if they don't have a comorbid disease, so they can tolerate very well topic anesthesia and midazolam. Bronchoscopy in the ICU, patients in ICU are high risk for and benefit must outweigh the risk. Pre-oxygenation بنفتح طبعا ال FiO2 to 100% before the procedure، وبنحط سويفل كونكتور نقدر ندخل بيه بالمنظار، ده شكله كده، ده يبقى الاندوتراكيال تيوب من الناحيه دي والتيوب سيستم للبرونكوسكوب كده، وانا بدخل بالمنظار بنفتح الكونكتور ده ونقدر ندخل بالبرونكوسكوب، بيبقى ده اير تايت ونقدر ان احنا نعمل البرونكوسكوب بتاعنا وهو العيان على الفنتليتور. بس انا لازم اكون عارف السايز بتاع الاكسترنال دايمتر والسايز اوف ماي برونكوسكوب. ما ينفعش انا بستعمل تيوب 7 ملم سايز والبرونكوسكوب بتاعي 5.5 ملم، يعني كده سايب العيان 1.5 ملم تو بريث ثرو، فده طبعا لازم ان انا ابقى ادي good airway for the patient to breathe. ولازم طبعا العيانين اللي فيهم هيد تروما ببقى عامل مونيتورنج للانتراكرينيال تنشن، عشان اي انكريس في انتراكرينيال تنشن من الكافنج بيبقى problematic to this patient. And thank you very much for your attention.
نشكر الاستاذ الدكتور محمد متولي على المحاضره اللي فعلا مهمه جدا، ان اي حد بيشتغل مناظير لازم يتعلمها، لان للاسف الشديد كلنا بنستخدم المناظير وما بنعملش البريكوشن ولا الحاجات اللي احنا بنعملها، يعني ان احنا نخلي بالنا من الحاجات دي. وقبل ما اقدم للدكتور صبور، بشكر الدكتور طارق صفوت طبعا والمجموعه. يعني انا صراحه لما قريت البروجرام، يعني بروجرام دسم وناس من كل الاماكن ويعني محاضرات قيمه جدا، فيعني والمجموعه طبعا الدكتور عادل خطاب وكل المجموعه طبعا عشان ما انساش حد، فانا اشكرهم جدا على المؤتمر الجميل ده. دلوقتي الاستاذ الدكتور محمد عبد الصبور هيقدم لنا مانجمنت كومبليكيشن اوف ان ذا برونكوسكوبي يونت.
بسم الله الرحمن الرحيم. يعني الواحد بيجي هنا يفنتليت بصراحه. اشكر الاستاذ الدكتور طارق صفوت والدكتور علي خطاب والدكتور ياسر والدكتور عماد والدكتور اشرف مذكور انهم دعوني ان انا اشارك معاكم تاني في المؤتمر. الواحد حاسس ان هو يعني لاكينج يعني الورم اتموسفير ده اللي احنا مفتقدينه في مكان تاني ان شاء الله. بصراحه الدكتور ياسر والدكتور اشرف مذكور بعتوا لي عشان managing complications in bronchoscopy suite. زي ما الاستاذ الدكتور الأبينا كان بيتكلم على البريباريشن او assessment to patient before bronchoscopy. I think this is much better than pushing the patient into complications and then start to manage. Proper assessment, proper evaluation, or proper choice of the procedure would prevent rather than manage complications. The first step to control or to manage complications to exclude patients with contraindications for bronchoscopy, either fiber optic or rigid bronchoscopy. Unfortunately, زي ما شايفين آخر لاين كده, most contraindications, especially for flexible bronchoscopy, are relative rather than obsolete. يعني في كتير نقول عندها very hypoxemic ومع ذلك يعملوا برونكوسكوب، عندها very critical not fit for general anesthesia ومع ذلك يعملوا برونكوسكوب. ساعات البرونكوسكوب هو الحل بتاع الديستريس او بتاع الكريتيكال سيتويشن اللي عند فيه. واحد عنده مثلا سيفير اوبستراكشن بنضطر نعمل له برونكوسكوب وهو عنده ذات سيفير اوبستراكشن ذات ريسبيراتوري فيلر to alleviate this obstruction to manage this critical situation. انما الجولد ستاندرد اللي بيهمونا قوي الناس اللي عندهم ريسبيراتوري بروبلمز والناس عندهم بليدنج بروبلمز اللي هم برونكوسكوبي بيمثلوا ميجور سيكتور في البيشنتس اللي subjected for bronchoscopy. لو العيان very unstable او مضطرين نعمل bronchial procedure, most bronchoscopists be referred to resort to rigid bronchoscopy even under general anesthesia. well known لو الواحد هيعمل interventional bronchoscopy تبقى الحكايه more and more sophisticated, more and more precautions should be taken into considerations. According to some papers, 4 main criteria should be fulfilled before thinking of interventional bronchoscopy. أول حاجة well-equipped facility. تاني حاجة trained personnel. Pre-operative evaluation اللي قلنا عليها قبل كده. و proper monitoring during the procedure and after the procedure for the recovery of the patients. على حد ما كنت شايف في الانتنسيف كير عندنا في الدمرداش في عين شمس كان في عندنا very equipped suite. معرفش طبعا دلوقتي السيتويشن ايه، انا اظن بقى احسن. I hope so. انما بيتكلموا على السايز بتاعت السويت بتاعت البرونكوسكوب، بيتكلموا على الاكسسبيليتي بتاعت الفاسيلتيز اللي موجوده، على النيرسنج اللي موجود، على المونيتورنج، على الفيزيبيليتي ان يكون في جنرال انستيزيا، نقلب جنرال انستيزيا في اي وقت، ان احنا ريسستيشن اب تو كارديو بالمونري ارست. حتى ان البريباريشن والريكفري بتاعنا شود بي ان سيبريت روم، واظن ده متوفر في مستشفى عين شمس الجامعه. نيجي لنقطة مهمة جدا، trained personnel. This includes the bronchoscopist, الانستيزيولوجيست والنيرسينج. الانستيزيولوجي should be very proficient. وعلى ما اذكر كنا في عين شمس كنا جينا في الاخر بقى في عندنا 2 أو 3 تيم بتوع انستيزيا هم اللي ديفوتد للبرونكوسكوبي يونت عندنا، بحيث ان هم بقوا اورينتد احنا بنعمل ايه والبروسيجر ايه وبنطلب منهم سبيشال ريكوست واحنا بالشارعين. should be professional مع الكونفنشنال والجيت والسنجل لانج فنتيليشن. ساعات نشتغل لانج واللانج الثانيه تبقى توتالي اوبستراكت سواء بالبروسيجر او بالتيومر ماس اللي قافلتها. interventional procedures at least لو احنا بنشتغل interventional procedure at least 1 or 2 nursing assistant. والبروسيجر should be done under general anesthesia. يبقى في الوقت ده لازم anesthesiologist ويبقى على الاقل specialized nurse اكسترا في البرونكوسكوبي سويت. كان في بعض الاحيان كانوا بعتوا لنا 2 anesthesiology مش واحد بس عشان نبروسيد بالبرونكوسكوبي. again البري بروسيجر ايفالويشن زي قلنا حوالي 10 15 كونترا انديكيشنز، واللي قلنا ان معظمهم relative rather than obsolete. continuous monitoring بالبالس اوكسيمتري. several procedures can be done by flexible bronchoscopy under local anesthesia وconscious sedation. انما لو احنا هنشتغل interventional bronchoscopy زي ما قلنا should be prepared ان احنا في اي وقت نقلب ب rigid bronchoscope وبجنرال anesthesia. نيجي بقى البرونكوسكوب اتسلف what is expected to be done. الليتريتشر كله بيتكلم ندي اتروبين ما نديش اتروبين، وده كان ديبيت فتره كده. وكان زمان لما كنا نواب كان خد اتروبين. البي تي اس does not advise the routine use of atropine due to many side effects that we face with. Mainly bradycardia, tachycardia, palpitation, arrhythmias, loss of pupillary accommodation, photophobia, dry mouth, flushing, whatever. انما ما فيش في الجايد لاينز دي what states when we are obliged to give atropine. انما last message in the pre-medication with anticholinergic drugs is not beneficial during bronchoscopy. دي الجنرال رول في الوقت الحالي. دي بقت fixed well known message. تاني حاجه السيديشن. في several studies بتقول ان الناس اللي بياخدوا ميدازولام وبياخدوا sedation just prior to bronchoscopy is much more beneficial، وان العيان هيبقى well tolerating ويحصل له امنيزيا بعد البروسيجر وهيبقى more or less at comfortable stage. انما الاستاديز اللي طلعت زي ما كان الدكتور محمد بيقول قبلينا كده، الاستاديز مفيش evidence based results تقول قوي قد ايه اللي كانوا with benefit without benefit. لان لقوا الناس اللي هم خدوا benefit من السيديشن دول كانوا وصلوا ل very high doses of sedations، مش الكونشس sedation up to ان هم very near to anesthetic يعني situation، وفي الوقت ده محتاجين واحد انستيتيوشن توقف معانا. وفي several results, several studies, several groups suggest that unsedated bronchoscopies are as tolerable as non-sedated bronchoscopies. وبالتالي دول زي دول بتعتمد على الاكسبيرينس بتاعت الدكتور، الكوبراتيف بتاعت قد ايه العيان كوبراتيف، قد ايه العيان كان توليريت، قد ايه العيان اكسبتنج البروسيجر. ولذلك في حاجه مشهوره جدا في البرونكوسكوبي الفيربال كونتاكت او الفوكال او الفيربال انستيزيا. بصراحه الواحد كان بيشتغل برونكوسكوب كان طول ما بيشتغل من قبل البرونكوسكوب لغايه ما بيبقى هو بيعمل بروسيجر، طول ما الواحد بيشتغل بيكلم العيان. دلوقتي هتاخد انستيزيا، دلوقتي انا هعدي مش عارف الفوكال كوز، هتحس انك مش عارف تتكلم، هتحس ان بشرقه بزورك ما تكحش. الانستراكشنز اول ثرو البروسيجر ده elevates the patient too much and allows him to accept the procedure. مش كده بس during البروسيجر لو حصل complications، بعض الكومبليكيشنز بتديبند على الكوميونيكيشن مع العيان. اما اقول له ديب بريث مثلا، خد نفس غويط، حصل له شويه هايبوكسيميا مثلا، هولد البريث مثلا عشان اعمل ويدجنج عشان خاطر في بليدنج موجود. كل ده الكونتينوس communication and verbal contact with the patient is of utmost importance up to anesthesia itself. نيجي بقى للاسف يعني مش للاسف يعني الباد الكومبليكيشنز. most complications البليدنج والريسبيراتوري بريشر والكارديو ارست والاريزمياس والنيوموديستاينم والنيموثوركس بيحصل الحمد لله في اقل من 1%، بروفايد ان احنا خدنا الفور مين بريريكوزايتس اللي هو السويت والبرونكوسكوبيست والمونيتورنج والنيرسينج. انها برضه فيري فاريبل. في جابانيز ستادي مثلا فور اكزامبل واصل فيها الكومبليكيشنز تو 1.79%، وفي امريكان to 6.8% after transbronchial lung biopsy. هل ده بيعتمد بقى على انه بيريجستر اي كومبليكيشن تحدث؟ هل بيعتمد على النمبر اوف كيسز؟ انما فيري فاريبل من سويت لسويت، من سنتر لسنتر، من برونكوسكوبيست لبرونكوسكوبيست، من اكسبيرينس لاكسبيرينس. انما الموست كومن كومبليكيشنز اللي احنا بنخاف منها بصراحه البليدنج والنيموثوركس. المورتاليتي ريت رير الحمد لله less than varying from 0 to 0.04 very rare. وكثير من الكومبليكيشنز دي الحكايه فيها اما احنا شفنا حالات يعني جاست بالهيفي سيديشن something like انافيلاكسيس عن ارستد بريسبيراتوري ديبريشن او الميجر بليدنج. دول التو مين كومبليكيشنز اللي ممكن يخلوا عن سادن ارست، او لو العيان مش ويل تشوزن مش ويل بريبيرد، عنده underlying disease arrhythmia recent infarction recent disease واحنا ما كناش او ده كان oversighted during preparation. To enumerated complications hypoxemia, bleeding, pneumothorax, arrhythmias, fever, pulmonary infiltrates, pneumonia, non-compliance with the patient, cough, anaphylaxis, shock up to cardiorespiratory arrest. So you are seeing from non-compliance عمال يكح بس مش عارف يعمل procedure لغايه cardiorespiratory arrest. So caution should be taken and you must be prepared and you must be supported. يعني الناس اللي بيشتغلوا interventional bronchoscopy دايما كده يبقوا supported في المستشفى ان في at least nearby facilities. For any reason we can seek assistance from cardiothoracic surgeon, from anesthesiologist that is well trained. أول complication الهايبوكسيميا. الهايبوكسيميا بتحصل في البرونكوسكوبي من 4-5 ميكانيزمز. اما يحصل برونكوسبازم او فيكيوم سماش او هايبوفنتيليشن بالسيديشن اللي احنا بنديها، او ان انا بعمل فريكوينت سكشن دورينج البرونكوسكوب بدون سبب او بدون لازمه، فانا عمال اسك الاكسجين واسك السكريشنز واعمل كولابس للالفيولاي والبرونكاي التيرمال برونكاي، او ان انا بعمل برونكال الفيول لافاج. البرونكال الفيول لافاج معروف ان بعديه بيحصل هايبوكسيميا اكتر من اي بروسيجر ثاني، اللي احنا بنجكت اتليست 150 مل سلاين، وخصوصا لو خدنا لارج فوليوم سلاين. والحاجه الثانيه ان معظم الناس اللي عندهم برونكال الفيول لافاج بيبقوا ناس عندهم اندرلاينج ديفيوز لانج ديزيز، فهو اوريدي اللي عنده هايبوكسيميك اوريدي بريديسبوزد فور هايبوكسيميا، اوريدي اللانج بتاعته كومبرومايز، او انه عنده انفكشن في اميونو كومبرومايزد بيشنت. هاو تو مانج. اول حاجه واهم حاجه البيشنت سelection، ان انا من الاول بختار عام مظبوط، continuous monitoring oximetry، continuous oxygen delivery او administration during the procedure بنيزل برونكس، avoid unnecessary suction. لو حصل هايبوكسيميا زي ما بقول كده الفيربال كونتاكت مع يعني جاست انه ياخد ديب بريث، جاست انه يكف، ساعات يكلير السكريشنز والاكسجين بتاعه يتحسن. احيانا ويزدرو البرونكوسكوب اب تو ذا كراينا اند ستوب فور ا وايل لغايه ما الاكسجين يتحسن ونرجع نخش تاني، او نوزدرو البرونكوسكوب وننتروديوس سمولر سايز برونكوسكوب. لو احنا مدين هاي دوز سيديشن ساعات نريفرس السيديشن دوت عشان العيان يصحى ويفوق. في السيفير كيسز لو العيان معمول له فايبراتيك برونكوسكوب بننتوبيت. لو احنا بنشتغل برونكال الفيول لافاج عاده بنقلل الفوليوم، نستعمل اليكوتس اصغر، او ان احنا نبوستبون اللافاج نفسه ديو تو سيفير هايبوكسيميا. لو انا شغال في اي سي يو ابقى متوقع ان العيان اللي عنده اكيوت سيسباتيك فيلر في اي سي يو ده يحصل دروب للبي او 2 بتاعه بنسبه حوالي 30%، والكلام ده يرجع في حوالي ساعتين بعد كده نورمال. الناس دول براير تو برونكوسكوبي زي ما الدكتور محمد كان بيقول اتليست اوكسجينيشن 60 ملم ميركوري او 90% ساتوريشن قبل ما نعمل برونكوسكوب في عيان بريسبيراتوري فيلر على ميكانيكال فنتيليشن. لو حصل له او مش حصل له جونينج برونكوسكوبي، لو احنا افريد او ستارت هايبوكسيميا، اما بنستخدم السي باب او زي ما الدكتور محمد النون انفيزيف فنتيليشن. البليدنج اول حاجه البيشنت سelection، تاني حاجه بنختار البروسيدور اللي احنا هنشتغله. ما ينفعش عيان يبقى احنا عارفين عنده بليدنج تندنسي يبقى احنا انسيستنج ان احنا عمالين ناخد ميني بايوبسيز ونبقى فيري انسيستاتيك ناخد بايوبسيز مور ذان ريكوايرد. نريفايز البليدنج دايسيس بتاعته، ناخد بالنا من الناس عندهم هيماتولوجيك ديس اوردرز او هيماتولوجيك مالجنسيز، الليمفوماز واللوكيمياز، العميل الاميون كومبرومايزد. ودورينج ذا بروسيدور ساعات الواحد يريزورت لبروسيدور تاني غير اللي كنت انا هشتغله قبل البروسيدور طبقا اللي انا شايفه في البرونكوسكوب. يعني دخلت شفت حاجه فيري فاسكولار I should not be very enthusiastic to take a biopsy from a patient who it seems to be very vascular. More likely انه يحصل في اليورينيك بيشنت والاميونو كومبرومايزد بيشنت اميونو سبريسد بيشنتس. significant bleeding rare او انه يحدث so long ان احنا بنكنترول البليدنج بالبروسيدر هنقولها بعد كده. الريبورتنج انسيدنس حوالي 26% في التي بي ان ترانس برونكال لانج بايوبسي، وقلنا بيزيد قوي في الناس اللي عندهم رينال انسفشنسي. قبل اي ترانس برونكال لانج بايوبسي اجريد في كل الليتريتشر لازم ستوب الانتي كواجولانتس براير تو ذيس بروسيجر. اهم حاجه في الواحد شاب بليدنج وهو بيشتغل برونكوسكوب الويدجنج. To wedge the bronchoscope in the segment in which this bleeding has occurred, especially لو دي transbronchial lung biopsy. حتى لو العيان ده جاي من سايت معين واحنا خدنا البيوبسي، لو احنا شغالين بروسيدور انترفنشن ساعات يبقى البروسيدور اللي احنا شغالين بيه ده هو الميثود اوف مانجمنت اوف ذيس بليدنج. الكرايوثيرابي از method of treatment for the bleeding. الكولد اجلوتيشن ساعات نحسن انه بنحط على العيان ده جاست كوتري كده بكوتري مع هذا الحلس. خلصت انا خلاص. عامل ازاي بالظبط؟ تاني حاجه الايس سلاين، تالت حاجه الابنفرين والنورابنفرين انستليشن بروفايد ان انا تشيكينج ومونيتورنج البلاد بريشر بتاع العيان. تالت كومبليكيشن مهمه بتحدث ساعات الفيفر والبكتيريا اللي بتحدث في البروسيجر، ودي نوت ذات كومن، بتبقى حوالي 2.9%. 2001 اولمبس كانت ويزدرون حوالي 15 برونكوسكوب من الماركت، كان في ديفكت في البرونكوسكوب اتسلف في التشانلز، بحيث انه كان بيسمح بالليك بتاع اللافاج وبتاع البروسيجر يخش في هذا الشانل، بحيث يبقى هو نفسه كروس كونتامينيشن بين عين والتاني. برونكوسكوب should be well sterilized to avoid this infection, this pneumonia. انما للاسف احنا عشان نعمل sterilization محتاجين ايثين اوكسيد that is not compatible، فبرضه النوشن او المسج دلوقتي ان احنا we disinfect rather than we sterilize the bronchoscopes. Glutaraldehyde هو المين ستي فور ذا disinfection of the bronchoscopes. take care للبرونكوسكوبيست والعيان من الجلوترالدهايد سيلف نفسه، هو نفسه يعمل complications في البرونكوسكوبيست وفي البيشنت if not well washed by the nurse. You should actively do surveillance for the bronchoscope and check the channels and take samples to be sure that there is no organism lodged inside the channels every now and then. This is very important. واحنا عندنا reported cases بحالات كانت بتشخص انها tuberculosis وهي مش tuberculosis، just ان الشانل بتاعت البروسكوب contaminated ب acid bacilli، يبقى العين malignant ويطلع ان هو tuberculosis. اخر حاجه الريجيد برونكوسكوبي، مفيش حد هيشتغل انترفيشنال برونكوسكوبي الا لما يكون بيعرف ريجيد برونكوسكوب. And this is a must now for those who are allowed to do interventional bronchoscopy. Complications mainly traumatic لللبس للتيث للجامز للكارنس tracheobronchial tree. Most complications of rigid bronchoscope are due to poor insertion, prolonged trauma لللارynx او الايروايز كلها، او ان حصل هايبوكسيميا او inefficient كنترول للايرواي والريسبيراتوري والكارديوريسبيراتوري ستيتس، واحنا اوفرلوكت الكلام دوت وان احنا محتاسين او احنا منهمكين او في البروسيجر. How to avoid training in rigid bronchoscopy should be reserved for physicians who have had extensive experience in flexible bronchoscopy and intratracheal intubation. Trainee should practice all many can at least 20 مرة before bronchoscopy and 20 supervised rigid bronchoscopy procedures before attempting this procedure. To maintain competency, the procedure should be performed at least 10 to 15 times per year. يعني دلوقتي انا ما اقدرش اشتغل بالريجيد برونكوسكوبي لان بقى لي اكثر من 10 سنين ما اشتغلتش ريجيد برونكوسكوب، بقى لي اكثر من سنه ما اشتغلتش ريجيد برونكوسكوب، فالمفروض ان انا دلوقتي لما اجي اشتغل تاني ريجيد برونكوسكوب نعم اقعد سنه الاول اتعلم من الدكتور عماد والدكتور اصافه والدكتور. اخر من سلايدز، لو اي حد فينا فتح الانترفنشن المال براكتس ان بالمونري هيلاقي اول ايتم البالمونري امبوليزم، ثاني ايتم على طول انترفنشن ان pulmonology، intervention in pulmonary medicine اللي هو اللي احنا دلوقتي شغالين فيه كتير بقى الليزر والالكترو. تاني حاجه في المال براكتس. اخر حاجه استاذنا الدكتور حسن حسني كان ليه كلمه مشهوره جدا، complications usually tend to occur towards the end of the procedure. الواحد لما يجي يشتغل البروسيجر يشتغل as fast as possible وعارف التارجت بتاعه، once finished التارجت بتاعته، once خد البيوبسيز once controlled البرونكوسكوب بتاعه you should terminate the procedure without delay يعني without يقولوا كده الحسوكه يعني. And thank you.
Thank you very much Dr. Abd Sabour. احنا we really miss you and thanks for the very elegant presentation. We promise you can restart practicing bronchoscopy. No problem. It's my pleasure to invite my dear friend Professor Semra from Turkey, Izmir, and Semra is professor and chief of the division of pulmonary critical care, professor of pulmonology, and in Izmir University, and she's the president-elect of the European Association of Bronchology and Interventional Pulmonology. Semra is very active and she's a bionic woman, so she's gonna address for us the EBUS and pulmonary thromboembolism. Semra.
Thank you, Dr. Safat, introducing me in such a nice way. I'm very happy to be in Cairo, in Egypt again. This is not my first time, maybe it's 5th time I'm here. I'm happy, and I want to thank you in your language, shukran jiddan, for inviting me to this meeting. As you all know, central pulmonary thromboembolism is the thrombotic occlusion of pulmonary trunk, main or lower pulmonary arteries, and acute pulmonary thromboembolism is rapid, unpredictable, and difficult to diagnose, and diagnosis must be therefore fast, accurate, since fatal emboli are usually central, and 90% of fatal emboli lead to death within 2 hours. In the diagnosis of pulmonary thromboembolism, the principal diagnostic imaging modality is chest CT with IV contrast, which is called angio-CT, but this works mainly for main, lower, and segmental pulmonary arteries. And CT is not always straightforward regarding contrast, radiation, and hemodynamic instability. Contrast can be a problem in renal insufficiency and may cause anaphylaxis. Radiation is a contraindication in pregnancy, say relative contraindication, but usually it's avoided. And short-term follow-up also is, in the short-term follow-up, radiation is a problem. Regarding hemodynamic instability, transport is risky for some patients to the CT unit. And there are more issues about CT angio. Angio-CT contraindications have been found to be 24% in PIOPET-2 study. When angio-CT is positive, angio-CT is positive only in 20 to 32% of pulmonary embolism suspected cases. This is not a very high percentage. And in ICU patients on mechanical ventilation, it's difficult to transport them to the CT unit. Angio-CT is currently the most widely used technique to diagnose pulmonary thromboembolism. Pulmonary angiography has limited use. It can cause fatal complications, and the radiation exposure is 5 times that of angio-CT. MR angiography is promising, but gadolinium can have nephrogenic systemic fibrotic effects. And ventilation perfusion scan, if normal, rules out pulmonary thromboembolism, but for intermediate and low probability ventilation perfusion scan, this is about 50 to 72% of the cases. There are more further testing required. Ultrasound, it's good in diagnosis of thrombotic venous disease. In 70 to 90% of pulmonary thromboembolism cases, the embolus arises from the leg deep vein thrombosis. If it's positive, there is no need to confirm pulmonary thromboembolism, but if it's negative, it does not rule out pulmonary thromboembolism. Another ultrasonographic procedure, transthoracic echocardiography, has low sensitivity in pulmonary embolism diagnosis. It shows right ventricular dysfunction in prone acute pulmonary thromboembolism. So currently there are no tests that are accurate, non-invasive, with minimal complications, and that can be applied in all cases for the diagnosis of pulmonary thromboembolism. As you all know, EBUS is good and efficient in diagnosing mediastinal and hilar lymphadenopathies, central masses in the mediastinum or in pulmonary areas. It is highly diagnostic in lung cancer, in staging of lung cancer, in diagnosis of sarcoidosis, tuberculous lymphadenitis, and other malignant diseases. It can also visualize pulmonary vessels that are close to the central airways, about in 5 millimeters distance. So it can be used to detect pulmonary embolism, avoiding contrast and radiation. Here we have a video showing the thrombus here in the pulmonary artery. The grayish side is the embolus. It's sometimes disappearing. This is the embolus, and the black side is the vessel, but it's fixed to the wall. It's a chronic thromboembolism. Maybe it will show again the thrombus, the blood, and it's not floating. It's connected to the wall because it's a chronic embolus. There is one good prospective multicenter pilot study to show the feasibility of detecting central pulmonary thromboembolism by EBUS. A convex probe EBUS bronchoscope is used under local anesthesia and moderate sedation within 24 hours after angio-CT was shown to be positive for pulmonary thromboembolism. EBUS images were compared to CT findings, and in the study, 32 patients had 101 pulmonary thromboembolisms detected by angio-CT, and in these patients, pulmonary thromboembolism was detected by EBUS in 96% of the cases. Only 4 embolus were missed, 1 in middle lobe, 3 in left upper lobe arteries. Here, you can see from the same study corresponding CT angiography and the EBUS images. Here, the embolus is in the left main pulmonary artery, and you can see the same thrombus at the EBUS image. Another case with emboli, bilateral emboli. Here also it's bilateral. On the left side, in the descending pulmonary artery, there is a thrombus, and the same thrombus is shown on the EBUS. In the same study, in all of the cases, pulmonary trunk, both main and left lobar arteries, and in nearly all, at least 10 millimeters of upper lobe and middle lobe arteries were very well visualized by EBUS. At least 1 embolus was detected by EBUS in each patient, and there were no additional embolus detected by EBUS. No bronchoscopic complications were seen, and the mean procedure time was 4 minutes. At the beginning of the study, it was 5 minutes, but as the experience progressed, the procedure time went down to 3 minutes. So EBUS is feasible for central pulmonary thromboembolism diagnosis. It's safe, but it can be used in hemodynamically stable patients, of course. It can be performed at bedside. It's moderate level experience needed. About 100 EBUS bronchoscopies are required to get experience. Training shortens the examination time, but there is limitation. It can only visualize central pulmonary thromboembolism. Other than this study, there are some case series and case reports. There are not many big studies because of the serious condition in pulmonary thromboembolism. In these case studies, most of the detection of pulmonary embolism by EBUS was to confirm embolus already shown by angio-CT. It was sometimes incidental or coincidental during EBUS procedure for staging lung cancer or diagnosing some other disease, or to detect pulmonary embolism that was missed but suspected. That was missed by angio-CT and was suspected of pulmonary thromboembolism. In this case series, one of them showed, it's one of the studies, the case report is from Turkey. They diagnosed pulmonary embolism that accompanied lung cancer. As you know, in tumors, pulmonary embolism is not very rare. And there were 3 forms: real thrombus, that was free floating and surrounded by blood flow; tumor embolus, that was fixed inside the lumen, and it was fixed to the wall; and tumor invasion from outside of the vessel. Here, the case report from Turkey. The right pulmonary artery has a filling defect, and you see the filling defect on EBUS. There is a mass-like filling defect. It's tumor embolus, and it's fixed to the vessel. It's not moving, it's not floating. And another view on Doppler. Other case reports mentioned about accompanying pulmonary thromboembolism in breast cancer, in thyroid cancer. In the one with breast cancer, lymph node was eroding into the pulmonary artery, causing a filling defect, and it was masquerading pulmonary thromboembolism. In the case with thyroid cancer, it was tumor embolism, which was anticoagulated, but there was no response to the treatment. There was a persistent filling defect, so it was tumor embolism. Here, the case with thyroid cancer and tumor embolism. You can see tumor embolism here and on the left here. And on EBUS, you can see the tumor embolism, and EBUS-TBNA is performed, and the diagnosis of thyroid cancer got. So they went into the tumor embolism inside the vessel with the needle and got the diagnosis. EBUS can be used in the differential diagnosis of pulmonary artery sarcoma, which initiates from the wall of the pulmonary artery most of the time, and it can differentiate sarcoma from pulmonary thromboembolism. And it's safe and feasible in differential diagnosis of these two diseases. If the filling defect is free-floating, pulmonary thromboembolism. If it's infiltrating the pulmonary artery wall, it's pulmonary artery sarcoma. And EBUS-TBNA done on the infiltrating lesion gives tissue diagnosis, as seen here. As you see, there is a filling defect, but it's infiltrating the wall of the left pulmonary artery, the image on EBUS, and the tissue obtained by EBUS-TBNA, which is pulmonary artery sarcoma. EBUS-TBNA can cause vascular complications. These are rare, but in case reports they are mentioned. They are not zero. There are some vascular complications, although rare. Here you see a case with intramural hematoma. There is a tumor involved lymph node, and there is EBUS-TBNA done. And during the EBUS-TBNA, there is a intramural hematoma occurring, and there is also pneumomediastinum occurring. These are very rare complications, but we have to know that they can occur. In conclusion, EBUS in the diagnosis of pulmonary thromboembolism is feasible, reliable, and safe, and can be used if CT angio should be avoided, can differentiate pulmonary thromboembolism from vascular tumors or the tumors that are invading pulmonary vessels. And however, blinded comparative trials are necessary to evaluate it as a primary tool. Thank you for your attention.
Thanks for Dr. Semra for this new indication for EBUS. And I am asking you if it is possible to use TBNA in injecting fibrinolytic enzymes for treatment of this pulmonary embolism?
Till now, to my knowledge, I don't know any study, but why not? If we can do EBUS-TBNA and go in through the vessel wall and get diagnosis from the tumor embolus, why not to inject a drug inside the vessel? That's possible, but to my knowledge, I didn't see any such case report or study. It's feasible, yeah, it can be done.
Okay, thank you. طب ممكن بعد دكتور طارق بس عشان now I will introduce Professor Dr. Tariq Safwat, the most gentleman of this conference and the head of the conference. He will speak about our intervention as rosy as they look.
والله شكرا انك بتقول لي جنتلمان يا شكرا يا شيخ خالد. Thank you, Mr. Chairman. يعني on behalf of the Egyptian Bronchology Board, I would like to welcome you all for attending our meeting, and hope we every year we meet together and we have this nice gathering. So I love intervention, but intervention pulmonology is not always rosy. We face a lot of problems, and we have to expect problems. So we have to take care. It needs practice, and intervention pulmonology plays an integral role in the management of critically ill patients, as we all know, with central airway obstruction, having massive hemoptysis and complications of thoracic surgery or radiation therapy, etc. So we're working in a very critical area, and it needs really practice, and we have to know the roadmap how we're going to tackle the problems. I'm not going to go through all this data, but the domain of interventional pulmonology is diagnostic and therapeutic. So this is all the diagnostic procedures from TBNAs, TBLs, ultrasound, which Semra just gave a hint about it, fluoroscopy, electromagnetic navigation, etc. So many procedures. And then we have all this armamentarium of therapeutic bronchoscopy, from stenting, balloons, electro, argon. Of course, we don't have in our practice, in our department, all these, but we stent, we do the bronchoplasty, we do mechanical dilatation, bougiage, we do the, we had the laser, but unfortunately the two equipments, the post-service was very poor and very expensive, so we cannot afford the laser bronchoscopy for the time being, and we shifted to the electro, which is the poor laser. And APC, we have it, cryo, brachytherapy, we don't perform it actually. We had a thesis about it, but we don't do it anymore. We don't have the photodynamic therapy. So it is, we have quite good facilities, and we've been through a lot of workshops, live workshops, wet labs with the different universities, Qasr Al-Aini, Ain Shams, Asyut University, Alexandria, etc. This was one of our workshops in Asyut University with late Professor Tariq Mahfouz. So we go into why it's not rosy. It's costly to perform a rigid bronchoscopy under general anesthesia with intervention. It costs in Egyptian pound not less than 4,000 to 5,000 Egyptian pounds in our university practice. It's only for the equipment and for the procedure itself with the general anesthesia, etc. The maintenance as well costs a lot of money, especially if you're not handling the equipment properly, you break the scopes, etc. So we have to be careful because we cannot afford expenses. We cannot afford to break something. Training. The golden rule in interventional pulmonology, which is not rosy, you have to be patient, and you have to have patience, and you have to have a proper training. If you don't train, you lose your practice. As Professor Absabur said, Muhammad Absabur, we need to train. You have to be always in the field and always working in the procedure. So rigid bronchoscopy is very important for any person, any doctor. He's gonna work in interventional pulmonology, he should know how to use the rigid bronchoscope. It's damn important. You need to have at least 20 procedures under supervision, and then to practice it at least once a month. At least once a month. TBNAs as well. If we're gonna do TBNAs, 25 needle aspirates at least, and 10 procedures per year. Autofluorescence, actually, we don't do it anymore, but we have the equipment, but it needs as well some skill to interpret the data you're gonna see in the field of airways. EBIS needs a lot of training, and it needs at 50 procedures at least, and 20 to get the skill to know it, and then 20 exams per year. Laser, of course, you have to know how to tackle the laser and electro. You can perforate the airway if you don't use it parallel to the airway. So you have to know, and you have to know when to tackle with a laser or electro, and it needs practice. It's not difficult, but it needs practice and it needs training. Cryotherapy as well. So I'm not gonna go through everything, but you need to train yourself, and you have to have a mentor. You have to have a mentor to train you how to use the equipments. Same thing for the stents. In our department, we use only the stents, the silicone stents, because they are cheaper. It costs about $300, which is equivalent to 2,000 Egyptian pounds, but we can afford it, and we have some funding about the stents. Another problem which is not really rosy, the general anesthesia. You have to have a teamwork, and you have to have a general anesthetic, and the general anesthetist should be well informed about the procedure, and to know that we're working in a very difficult area, very bleedy, very vascular. We're working near the heart and the major vessels, so he should be informed, and when to go down with the oxygenation, etc. It needs patience, and it needs practice, and you have to have a real anesthetist knowing what we're facing. Bleeding has been mentioned, and this is a major complication. If you shoot on an artery or you perforate something, you can get serious. You're working near the aorta, so you can get a spurt of severe hemorrhage. If it happens, you have to switch the patient on the same side of the bleeding, so he doesn't get any flooding on the other side, and you have to oxygenate him well. And don't ever remove the scope. Don't ever remove the scope. Keep it in until you coagulate or you make stasis for this bleeding. Trauma. If you're not experienced, you can make a fissure, you can lacerate the trachea, you can get major problems, and you can have a tracheal tear even with the endotracheal intubation. So you have to know how to especially the rigid scope. The neck should be flexed and hyperextension of the atlanto-occipital joint, and to know how to push gently the bronchoscope without causing any damage to the upper airways and lower airways. So foreign body, whenever you get a foreign body extraction, you can get the needle out, and then with getting out the needle, you're successful of getting out the needle, the foreign body. But the needle, the pin of the needle, will make a fissure or can make a fistula of the trachea to the esophagus, and that will be a real major complication. We can have pneumothorax with the transbronchial needle aspiration and transbronchial lung biopsies. Pneumomediastinum is common, and it is a complication which can happen in those not having the real experience where to take the biopsy, how to perform it, and if you're going to perform a transbronchial lung biopsy, don't take the biopsy near the pleura. So these are indications and some issues that we have to take care of. Whenever you do the electro or cryo, you can get bronchospasm, and you can get tumor hyperemia, and this has been reported in the practice. Whenever you're doing extraction or debulking, after the debulking you get edema and hyperemia of the area where you worked on, and you can develop spasm and airway obstruction. Airway stenosis or re-stenosis. We face the problem of the point which I raised with Professor Islam today, that we get a lot of tracheal stenosis post-intubation. I know that's a problem in the intensive care. Maybe we don't calculate exactly the pressure of the cuff pressure, and I'm always pushing that we have to monitor the pressure of the cuff less than 25 centimeter water. But we face it a lot. We face it a lot, and when we do the point of debulking and to dilate it, we have some points that the 12, 3, 6, and 9, and we swab it with the mitomycin so we don't get recurrence of the. But still, we can get, and sometimes if it's a wedge or it's a concentric, we send it to the surgeon. If it's funnel shaped or it's a bottleneck, so sometimes we shift it to the surgeon to remove this obstruction. Anyhow, this is an endobronchial fire, which I took it from my dear friend Ahmad Urra, and how to do it. That's just to show you what happens if you're doing bronchoscopy and the anesthetist is sleeping and he gives the patient more than 40% oxygen. You get fire here. And he's saying, thank you, Ahmed, for this beautiful movie. You get fire, and the poor guy was shocked, and he injected cold saline, as I remember. Ahmed, you can discuss it with the it is a problem. So you have to instruct the anesthetist, please go down the oxygen less than 40%. In spite that some centers in Germany, like Henrik Becker, he tells me that this is not important, but I believe that more than 40% you can get ignition and get fire. Infection, another unrosy problem when we do it. Whenever you put a stent, you have to inform the patient that every 3 months you have to have a toilet and to wash the mucus stasis which happens on the stent. Migration, that's another problem, and you can get stridor and suffocation of the patient if you're not alert. The stent should have been here, it migrated to the epiglottis, and it can cause suffocation. So you have to know how to insert the stent and to repeat the examination to be sure that nothing happened and it's still in its position. Fatigue or fracture, which happens a lot with the metallic stents. And by the way, don't ever insert a metallic stent in a benign lesion. It's very, very difficult to extract the metal stent if you're doing it in a benign, if the patient is having a terminal condition, a terminal bronchogenic tumor, that's another story. But in a benign lesion, you never insert a metallic stent. This is our modest team. You know all these guys, of course. And this is our maestro here. And one of the unrosy problem that at the end of the session you're extremely fatigued. I mean the operator. So this is what you see. This picture was taken after the fire. مش كده يا أحمد؟ And the poor guy was sleepy. I had to take him back home to his wife. And he had a good sleep in the car anyway. Thank you very much.
Thank you very much, Professor Tare, for your very illuminating and illustrative presentation. الحقيقة ما أقدرش أسيب الجلسة دي غير لما أقول زي ما قال سبحانه وتعالى ولا تنسوا الفضل بينكم. الحقيقة الجلسة دي على مناظير الشعب الهوية لا يمكن أنسى فضل زميلي وأخي العزيز الأستاذ دكتور حسن حسني اللي تزاملنا على مدى من الستينات حتى انتقل إلى رحمة الله، وهو اللي عمل وحدة وفريق وأعضاء هيئة تدريس متميزين في هذا المجال، ودخلوا كل الانترفنشن بروسيدرز في البرونكوسكوبي من براكي لكرايو لليزر لستنس لإبيوس وهكذا. وهو اللي دخل المنظار الشعب الهوائية الليفي أو الفايبر أوبتيك برونكوسكوبي في مصر. وفي هذا الوقت لقى معارضة شديدة. اللي كان ماشي الأول الريجيد برونكوسكوبي قالوا إزاي هتدخلوا الفايبر أوبتيك برونكوسكوبي، ولقينا دلوقتي الناس كلها اعتمدت على الفايبر أوبتيك ونسيت الريجيد برونكوسكوبي. إنما نصيحة للزملاء اللي في الجامعات والمراكز المختلفة إن كل سنتر عنده ريجيد فايبر أوبتيك برونكوسكوبي لازم يبقى تريند على الريجيد برونكوسكوبي، لأن في بعض الأحوال الانترفنشن او الكومبليكيشن تحتاج انه يشتغل بهذا المجال. كان الاخ محمد متولي عنده سؤال او كومنت عايز يقولها.
Many thanks for all the presentation, Professor Tare Safat. As usual, excellent presentation. My question is for Semra. I enjoyed your presentation very much. I see that only there are 2 points that may be not rosy in this endobronchial ultrasound for detection of pulmonary embolism. The first one is that the pulmonary embolism patient is a critically ill patient, usually hypoxic, with respect to the stress, especially if this is central, if this is massive pulmonary embolism. So are you going to bronchoscope this patient to detect pulmonary embolism? I mean, for people who are not able to do CT angio. The second one is you go directed to the site of the pulmonary embolism because you know where the pulmonary embolism is from CT angio. You know where the pulmonary embolism is from CT angio, and you go directly to the site to see what is the picture in the bronchial ultrasound. But what about if you don't have this CT angio? Do you have to scan the whole tracheobronchial tree, especially if this is a lobar far away with the endobronchial ultrasound, inch by inch, to see if this here, not here, then you go distal? I mean, it's maybe not practical. Right? Thank you.
Thank you. The first question, I also emphasize that this can be done in hemodynamically stable pulmonary embolism patients. Not all centrally located pulmonary thromboembolism is in hemodynamically critical position. I have seen many patients having a big embolus in the right or left main bronchus, but coming to the outpatient department saying that I have some dyspnea, or they're not always hemodynamically unstable. So we have to be careful to have EBUS on pulmonary thromboembolism patients who are hemodynamically stable. Or you can watch the patient for a while because the thrombus does not go away in just a few days. And also this topic is very new. I mean, it's not in routine practice. Not everybody knows everything about it. There is only one good study and the others are case reports. So I don't have a lot of experience because I had only one patient and it was just incidentally found. It was lung cancer patient having thromboembolism beside it, and I was not aware of it. And the CT was not an angio-CT. I was just trying to see the lymph nodes, and then I saw the embolus in the pulmonary artery. So maybe we need some time, further studies. The second one, what was the question? Okay. Again, most of the patients are having angio-CTs, and then, this is kind of curiosity, whether to do it is ethical or not. If you are doing a study and if you get the ethical permission, maybe you can do. But the others are usually incidentally done. If somebody sees the embolism in one pulmonary artery, you can go and check the other arteries too. So to the second question, I cannot give you a systematic answer because we don't have enough accumulation of knowledge.
Thank you for attending this session, and it's time for coffee break, and we reconvene after 20 minutes.